to the Thyroid Stimulating Podcast. This podcast is created in partnership with the American Thyroid Association to discuss up to date diagnosis and management of a wide array of thyroid diseases. I'm your host, Dr. Kaniksha Desai. Today, we're highlighting a milestone event, the release of the 2025 ATA guidelines for the management of differentiated thyroid cancer, which is already one of the top trending articles on PubMed. These guidelines introduce the new data framework for clinical decision making, refine risk stratification by adding a fourth category of high intermediate risk, and provide up to date updates on active surveillance and thermal ablation as treatment options for thyroid cancer. They also revisit the appropriate use of radioactive iodine treatment and the role of TSH suppression, while incorporating new recommendations on genetic testing. Finally, and importantly, they shine a spotlight on long term cancer survivorship care, emphasizing quality of life, financial toxicity, and patient centered care. In this episode, we'll explore what's new, why these updates matter, and how they're expected to shape thyroid cancer care in the years ahead. Joining us today is Dr. Julianne Sosa. Dr. Sosa is the Leon Goldman Distinguished Professor of Surgery and the Chair of the Department of Surgery at UCSF. She is an internationally recognized endocrine surgeon and pioneer researcher in thyroid cancer with more than 400 peer-reviewed publications. Dr. Sosa served as the president of the American Thyroid Association in 2023 and is the co-chair of the committee responsible for writing the current differentiated thyroid cancer guidelines. She is also the editor-in-chief of the World Journal of Surgery and recipient of numerous honors, including the ATA Distinguished Service Award and UCSF's Chancellor Diversity Award for the Advancement of Women. Her research has been supported by the NIH and FDA and has shaped how we think about cancer outcomes, clinical trials, and healthcare delivery for thyroid diseases. Dr. Sosa's career has been defined not only by academic excellence, but also by her commitment to equity and advancing surgical science. Thank you for joining us today, Dr. Sosa. It's an honor to have you here on our podcast.
Thank you so much, Dr. Desai. It's an absolute privilege.
Before we delve into the details of the new recommendations, I'd love to start with the process itself. So, updating national thyroid cancer guidelines is a huge task. It takes years of work and coordination across multiple specialties. So, what was it like for you to lead and contribute to a project of this scale?
That was an understatement. I literally just woke up. I've been asleep for the last 7 days since the publication of the guidelines and this taping. I guess to start, all joking aside, it was a humbling experience and an absolute privilege bestowed upon Dr. Ringel, who was my co-chair of the task force, and me. So humbling and privileged. I will also say it was at the same time energizing and exhausting. The process, it's hard to believe, began more than 5 years ago, actually closer to 6 years ago. And that means it started before the pandemic. Not to make excuses, just explanation is that the pandemic really delayed the guidelines because all of us, I think, were distracted for a very long time with management of the virus and its impact. So, a ton of work, but really important work. And I think the reason that the process was long is not just because of the pandemic as a barrier, but because this area of investigation and of science is incredibly dynamic. Every time we thought we had a sense of the contemporary landscape, there would be new science and a revision of our focus. And so ultimately, we had to call it, and we called it as of July 1st, 2024. So that was our cutoff for evidence. I think the learning I've made from this is that going forward, given how chaotic and kinetic the world is, A more perhaps dynamic guidelines writing process would make sense to be able to accommodate the innovation and discovery going on.
So similar to what we have for the NCCN guidelines and for diabetes care, would there be like kind of a yearly update or every other year update?
It's a great question. And that's really a question for the American Thyroid Association and its leadership. I think there are many different ways to think about doing it. One is a kinetic process for all of the guidelines. Another approach could be a modular approach where, on some kind of cycle, you break the guidelines down into discrete parts, whether it's, early diagnosis, imaging, surgical management, dynamic risk stratification, or the management of advanced disease and ultimately survivorship. So I think different approaches could be taken, but done at 5-year intervals, it's really a Herculean task.
Yeah. What was the biggest motivation? Just the new research, or was there anything else that motivated this update?
Well, yeah, I think some of it is the dynamics of the science and innovation and discovery that we see going on. But I think there, to be honest, are many other powerful forces going on in American medicine that I think it's really important that practice guidelines reflect. I think one of those is patient centered care and the idea of personalizing what we do for patients, especially in an area like thyroidology and definitely differentiated thyroid cancer, where there's perhaps a relative paucity of randomized controlled trials, prospective studies with consecutive patients enrolled. That may be more the domain of cardiology. I think in thyroidology, there's a lot more retrospective studies, systematic reviews, meta analyses. There's a ton of ambiguity and different critical points in the management of patients where you could do X or you could do Y. Ultimately, the long term outcome is similar, but while there may not be a best treatment or a best approach, there probably is a best treatment or best approach for a specific patient based on their lived truths. So I think the idea of developing guidelines that value shared decision making between the patient and their clinical team. I think that's one. Two, recognizing this idea of patient preferences, reflecting values and attitudes. I'm a surgeon, I'm an endocrine surgeon, and the amount of new technology and new techniques that now exist, I think, have not only provided complements to surgery, but maybe even replacements to surgery. And I think when it's all said and done, there definitely are some takeaways. And I think this is being seen across all areas of oncology. One is overall a de escalation of a lot of care, certainly for the majority of patients with low risk disease. But for patients with high risk disease, the idea of more is more and figuring out how to do that most effectively.
So, a lot of what I'm hearing is a lot of patient centered care. And so, what you would do for patients might differ based on where they are in their lifespan as well. For patients who are younger women would be different than patients who are male and elderly. So, that actually brings me to my topic that, you mentioned that there's not a lot of randomized controlled trials, right? So, how comfortable are you on recommending different treatment options? And how did the committee balance, this is a high level of evidence versus a low level of evidence to support decision making?
Yeah, thank you for that question. So I guess one thing that our group did that hadn't been done in the past was to do our own science. So, as we did our literature review, we recognized that there were several areas where there was just a relative scarcity of data, at least prospective data, consecutive patients, randomized controlled trials. And so, for these areas, we said, let's do some original science to help fill the gap. Fortunately, our task force had on it a methodologist for the first time, Dr. Roger Chu, who also works with the World Health Organization and with the U.S. Preventative Services Task Force. And so we conducted two systematic reviews, meta analyses, one looking at this critical area of active surveillance as an alternative to upfront surgery for patients with very low and low risk tumors, primarily papillary thyroid cancers. The second area is an interesting area, and that is an area that grew out of the rise of a less is more approach to surgery for low risk cancers. So in 2015, we introduced this idea of either performing total thyroidectomy or thyroid lobectomy for patients with tumors 1 to 4 centimeters in size that did not extend outside the thyroid and that not had not spread to lymph nodes. As a result of this, we've seen practice change in the United States, and the number of total thyroidectomies, certainly with radioactive iodine, has gone down, and the number of thyroid lobectomies and total thyroidectomies without I-131 as an adjunct have gone up. But then the question is, how do we follow patients? Do we do it in the same way that we've always done with thyroglobulin and thyroglobulin antibody levels, or perhaps these metrics are no longer meaningful? So the second systematic review and meta analysis was to try to understand if TG and TG antibody levels are useful or not, following now the three different approaches that can be taken, extending from total with I-131 to total without I-131 to thyroid lobectomy. So those were both published in 2022 in the journal Thyroid. I think the second thing is you can't be prescriptive, right? When the evidence can sometimes be soft. So we try to create guidelines where there are options presented. For instance, when it comes to extent of thyroid surgery, while definitely we see the rise of thyroid lobectomy, we actually say patients together with their clinicians can continue to choose total thyroidectomy, even if they don't need to have total thyroidectomy to achieve the same long term outcome. Why? Because patient choice, clinical nuance, these cannot be captured in the on average approach that guidelines take, if that makes sense. So I think that's how we tried to do it. And then we modified the third thing, I guess, is we modified the grade system. We used modified grade, where, as you said, there's a binary recommendation hierarchy of, strong and conditional, but they can be partnered with any level of evidence. So you can have a conditional recommendation with high level of certainty and vice versa. And if you can't figure any of that out, which we sometimes couldn't do, we have the good practice statement where we're frank with the reader. There are not data to inform this recommendation, but the committee, with 100% consensus, excluding those who had to recuse themselves, believe this to be true. So by giving the reader that transparency, I think the reader hopefully can take away sort of where there's nuance and opportunity to depart from the recommendation or not.
Well, thank you for sharing that background on how we came about with these guidelines. I wanted to dive into the guidelines now. So there was one of the major things that this committee did was creation of the data framework. Can you talk a little bit about the data framework for our listeners?
Sure. We should point out to listeners that while in 2015, thyroid nodules and differentiated thyroid cancer were lumped together in a single set of guidelines, for the 2025 guidelines, they have now been separated. And differentiated thyroid cancer guidelines came first. Susan Mandel and Lisa Orloff are leading the group writing the thyroid nodules guidelines, and I expect that they will be published sometime probably in the next year. So the D of data framework is an important D. It stands for diagnosis. And the specific diagnosis is a diagnosis of differentiated thyroid cancer. So to enter the guidelines, you have to have papillary thyroid cancer, follicular thyroid cancer, oncocytic carcinoma, or one of the variants of those. So that's the D. You start with a diagnosis of DTC. You then go to the first A, which is assessment. And I think basically what you're starting to see is it's following the patient journey, right? What the clinician does from the first time they meet a patient in clinic or receive a referral all the way to the survivorship phase. So, assessment is a combination of biochemical testing, genetic testing, somatic testing, imaging, biochemical testing to risk stratify the patient in order to get to T, which is treatment. And when I say treatment, a lot of people think treatment means surgery, but if you've now read these guidelines, you know that it may mean surgery, it may mean active surveillance, or it may mean a percutaneous interventional technology. So T is treatment broadly defined. And then obviously, after you treat a patient, this is a dynamic process life. And so you have to reassess. It's the second day, but it's a reassessment of the patient to look at their response to treatment. And then the important thing of the data framework is patients recycle, right, through this sort of life cycle until they either depart because there are low risk patients who have excellent responses to treatment, who we are saying may enter a phase of remission and where we may actually discharge them from the care of an endocrinologist. And for those who have persistent, recurrent disease, intermediate, and high risk cancers, then it's data again and again and again.
Okay, so you could do it at each step of the process. Just for our listeners, I know you kind of alluded to this, but this does not include medullary and it does not include anaplastic thyroid cancer. So those are two separate categories. And then when we're going through this data, the risk categories are now divided up into four instead of the traditional ones that are the three in the 2015 guideline. Can you talk a little bit more about what came to the decision of splitting the intermediate risk into low risk and high intermediate risk?
If you get the journal thyroid, you will see figure two, probably going to be the most famous or infamous image from the guidelines. And figure two is basically a heat map that's similar but not the same as the one that was introduced in 2015. It was black and white. It was a single arrow lumping together all differentiated thyroid cancer. And in this new figure two that looks at risk factors predicting the likelihood of recurrence, you will see, first of all, there are three arrows, not one. And the three arrows are we've now broken DTC into the three broad categories of papillary thyroid cancer, follicular thyroid cancer, and oncocytic thyroid cancer. Secondly, we introduced Technicolor, and it has the colors of the rainbow rather than black and white. But I do want to let folks know if you're printing these out black and white printer, they are available in the supplement in a gray scale. The third big change I think you have highlighted, and that is we've taken the three categories of high, intermediate, and low risk and made it into four categories for each of the histologic subtypes. And importantly, the intermediate risk has gone to intermediate high risk, risk for recurrence, putting patients in that category at a 16 to 30% risk of a recurrence, and then the intermediate low group, which is the 10 to 15% group. And there are different risk factors tracking to each of those groups. Like, for instance, in the intermediate to high risk category, we have risk factors like aggressive histology and vascular invasion. These are much more compelling for putting patients at higher risk. In the low to intermediate risk category, we have less compelling risk factors, like, say, microscopic extrathyroidal extension or unilateral multifocality. Now, I do want to say to everyone that when you use figure two or this risk stratification figure, I think it's important to understand it's really not meant to take any one criterion and use that one criterion to drive everything you do. We really want to encourage everyone to take this figure and these risk factors and, first of all, compile them into the portfolio that should include other really important things like, AJCC 8th edition, to imaging, to thyroglobulin and thyroglobulin antibody levels. So it's really intended to be used for a combination of factors. And why did we break that group? I think that the intermediate risk group continues to be vexing for many people. It's not a small number of patients. And it's a group of patients where I think there has been and will continue to be some degree of controversy about what to do, whether to give radioactive iodine, whether to not give radioactive iodine, how intensively to surveil them. So it was trying to give a little more granularity, a little more specifics to clinicians.
So, just to clarify, I know this will be a little bit of overgeneralization, but for patients who are the high intermediate risk group, they're more likely to receive radioactive iodine and have more intense follow up, at least initially, until they can get to their excellent response. And patients who are more in the low intermediate risk category, you could consider, watching and waiting for the radioactive iodine and spacing out long term follow up for survivorship care. Is that my understanding is correct?
I would say less hard and fast, less hard and fast. And I say that as a surgeon. And, my comfort zone is in surgery and not in some of the areas where maybe higher pitched voices, higher volume is used about you should or shouldn't do anything in radioactive iodine. But I think you're right in saying that it's a gradation, right? And it's a gradation where you try to assemble as many pieces of information as you can that ultimately allows you to best personalize the care to the patient, but also, if there is controversy, allowing the patient to participate in the decision making. So I just don't want to lose that little bit of nuance.
And then you talked a little bit about de-escalating care. Can you specifically focus more on what led to the de-escalation of care, just like research and outcomes, and why we're considering more de-escalation?
Yeah, I think, first of all, what is happening in differentiated thyroid cancer and thyroidology, I think, reflects larger themes in medicine and certainly in oncology, themes we're seeing in prostate cancer care, breast cancer care, and thyroid cancer care, where if a patient has a low risk tumor and an excellent response to treatment. And of course, there are exceptions to every rule. Perhaps a less is more approach can be taken. Why? Because some of the treatments we deliver, all treatments in some way, have risks that are not outweighed necessarily by the benefits that they afford. I mean, I'm a thyroid surgeon. I'm a high volume thyroid surgeon, which means on average, my outcomes are better than a low volume surgeon, but no volume surgeon is perfect, right? And if you do more surgery, there is more chance, even in the hands of a high volume surgeon, for a compromised outcome. And so, if two different strategies afford the same long term outcome, but the smaller strategy provides superior short term outcomes, what we're saying in the thyroid surgery section, we're being more sort of specific about doing thyroid lobectomy. And so to pull it out for people for low risk differentiated thyroid cancer in 2015, we said total thyroidectomy or thyroid lobectomy are equivalent and are on an even playing field. In 2025, for patients with tumors 1 to 2 centimeters in size, so now we're breaking down the 1 to 4 centimeter interval and saying if you have a smaller tumor, 1 to 2 centimeters, thyroid lobectomy, dare I say, we do say, should be the procedure performed. So prescriptive should be. Now, that is barring there being other activity on the contralateral side or other exceptional circumstances, a history of radiation, of family history. So there are, exceptions. And then if you have a slightly larger tumor, 2 to 4 centimeters in size, we're giving a small edge, a smaller edge, but a small edge to thyroid lobectomy, where we say thyroid lobectomy may be the preferred strategy. And very simple. The data that have been assembled since 2015 demonstrate equivalent outcomes long term, but superior outcomes short term for the thyroid lobectomy for this specific group of patients, which is why we are advocating for de escalation of surgery.
And speaking of de-escalation, we're going to take that like one step further with these new thermal ablation techniques for treatment. Can you talk a little bit about what you guys included in the current guidelines for using these techniques, such as radio frequency ablation, microwave ablation? So I think this is kind of where we're headed in the future too.
Yeah, totally. Thank you for that question. And you're highlighting right up until our finish line, one of the most debated topics, because it is one of the areas of research where there is the most dynamic, and that is alternatives to upfront surgery for very low and low risk differentiated thyroid cancer. The first alternative that had been mentioned in 2015, just with a two-letter word, if surgery is performed for these small papillary thyroid cancers, which just introduced a concept of active surveillance. Well, in 2025, we are saying that active surveillance for a specific curated subset of patients with these tumors, it can be performed as an alternative to upfront thyroid surgery. How do you do active surveillance? With ultrasonography. Thyroglobulin antibodies are not reliable as active surveillance tools. But then, in the time we were writing these guidelines, we said perhaps there is even a third alternative, and that is a percutaneous ablative technology. So, this has been a focus of our group's review over the last couple of years, which accelerated over the last year, and where we ultimately came out and said percutaneous ablative technologies can also be an alternative to a carefully selected subset of patients with very low and low risk PTCs. I'm sure there are skeptics, but a lot of people, I think, in the short time that the guidelines have been published, have really embraced this. They feel that it reflects care that is evolving, but they have asked, why did you not talk about what you mean by percutaneous ablative technologies? And this is an example of where I don't think there is enough high level generalized data to be able to yet call out one technology over another. But where we do feel a lot depends on the unique institutional milieu. So, where you practice, if whoever is performing the percutaneous ablation, if it's your radiologist, if it's your surgeon, if it's your endocrinologist, if it's a combination of folks, seeing what they use and what they do well. Very few centers can accommodate the whole spectrum of approaches. Usually one or maybe two have been introduced where there's expertise. So we wanted to make sure that people understand and reflect local institutional milieu.
Can you just review for our listeners currently what options are available when you refer to percutaneous techniques?
Yeah, a lot depends. Percutaneous ablative technologies appear in a couple of areas in the guidelines. The really new area is upfront as an alternative to upfront surgery for very low and low risk papillary thyroid carcinomas. So that's new. An area that is not new is in the use of patients with recurrent disease who require remedial treatment, like in my practice, fourth, fifth, sixth, seventh surgery or other intervention where risks start to exceed benefits and where percutaneous ablation is a safe alternative, or say in a patient who's elderly, infirm, and surgery is too risky. So, what can be used? It's an array of things. There's radio frequency ablation, there is cryoablation, there is ethanol ablation, laser ablation, combinations of all of the above, and even new techniques that we are reading about all of the time. And that's where I think understanding the expertise that you have access to is really, really important. And quite frankly, this is so dynamic since our July 1st cutoff. We've started to see consensus guidelines being issued, and where I think we're probably soon going to see an even stronger recommendation coming out.
So, more to come on that in the future for people to read about. I noticed one of the other things in the guidelines was more emphasis on molecular genetic testing. Can you talk a little bit about that?
Yeah, so molecular testing, wow, moving so quickly and really was almost absent in 2015. A very dynamic and controversial area, I will say, internally within our group. Broadly speaking, and obviously after this, please know that I'm making a few sweeping generalizations. It's really important that everyone look very carefully at the specific words we chose. We really agonized about so much subtlety. But I would say molecular testing definitely rising in importance in the management of differentiated thyroid cancer. I think we look at its use, broadly speaking, in three areas. So the first area is preoperatively. How should you use molecular testing? And the first thing we say is if you have molecular testing results, um, why would you have them? Say the patient started out with an indeterminate thyroid nodule. A third of thyroid nodule patients, I think, have indeterminate cytologies. It may have been ordered to refine the risk of benignity versus malignancy. So, if malignancy is demonstrated and you have the results of the molecular test, use those results. Don't ignore them. Should we routinely molecularly test every single new patient with DTC? Our recommendation so far, at least as of July 1st, 2024, was to not do that. Now, where there was some debate in our group, and I will tell you my own bias, is I think there is potential role, and that is in the CT2N0 tumors. So these are the tumors I just talked about, say 2 to 4 centimeters in size. You could do a lobe, or you could not do a lobe, although we're saying maybe lobe is better. So some degree of ambivalence. And that may leave some patients ambivalent or some clinicians ambivalent, particularly, say, referring physicians who don't have access to a high volume surgeon and you're not sure what to do. Could the results of molecular tests guide extent of surgery? So in the discussion, we talk about these potential roles, but it is absent in a recommendation. Then the next question is, okay, now you've done your surgery. You have, say, a papillary thyroid cancer, say low or intermediate risk. Should we do molecular testing routinely? The answer is no. Why? Because we do not feel there are prospective randomized control trials with consecutive patients that allow us to, with confidence, justify the cost and all the other things, anxiety, risk of misinterpretation of results, I'll come back to. So we say don't do that either. Well, when should or could you do it? Definitely three times the charm is in the management of a high risk patient where surgery is no longer appropriate, where you have radioactive iodine resistant disease and you are looking for druggable targets, the ability to better prognose patients, you should do it. And then the newest area in surgery, of course, deploying neoadjuvant therapy to be followed by surgery for patients who present with locally advanced disease. I think if you're considering neoadjuvant therapy, you also must do molecular testing for those patients. So I think that's at a high level what we're recommending. I would say one thing we thought a lot about is how people use molecular tests. And I think a big area of opportunity going forward is for all of us is education. And an example would be the BRAF V600E mutation, probably the best known mutation associated with papillary thyroid cancer, one of the first understood to be associated with it. I think people remember that and remember that it's a high risk mutation. But of course, that isn't the case now that we understand the mutational landscape of differentiated thyroid cancer. And we understand better that it's probably an intermediate risk mutation in isolation. It shouldn't be driving a change in management. But as we start to compile molecular profiles and combine different mutations, absolutely. BRAF combined with a TERT mutation takes on a very different meaning. So I think as we think about the role of molecular testing, what we have to do is improve dissemination of knowledge and communication so that when data are obtained, people use the data wisely. Does that make sense?
Yes. So, because I was just thinking, a lot of people think that maybe it's not recommended because of cost, but it sounds like it's much more than just cost. We want to make sure that you can use that data in like an efficient manner and actually not harm the patient because of educational things about the mutations that have since come out.
Yeah, cost is always a factor, and I think probably is the number one barrier for molecular testing, becoming universal internationally, right? We're so privileged here in the United States that we have access to multiple commercially available tests for which there's evidence to support its use. But in much of the world, there is no molecular testing.
So, Dr. Sosa, can you talk a little bit about the addition of the terminology complete remission in these guidelines? I know that's new as well.
Yeah, so thank you for that question. The lexicon of thyroid cancer is a quirky one, just like our staging system is so quirky through AJCC, UICC. But for whatever reason, thyroid cancer, unlike every other area, at least of surgical oncology that I'm aware of, uses the term complete remission, which is intended to define the disappearance of all signs of cancer in response to some treatment. And it's something that has never been used in prior guidelines, and certainly I don't think is a term used in practice. We introduced the term complete remission into these guidelines, and we do it to sort of bring thyroid cancer closer to the mainstream to make it potentially more accessible to more physicians. what I think it's important to convey is that when we say complete remission, we are not implying that, the cancer has been cured or cancer will never return. And so I don't think we're trying to mislead, but I think rather to mainstream lexicon and terminology in order to align. I will say there is a subset of patients, those with low risk, very low risk, and low risk tumors who have an excellent response to treatment, who, if that appears to be a durable response over, say, 5 to 8 years of follow up, we may actually discharge patients from care, returning them to their family practitioners or general internal medicine.
Which actually is great for survivorship care. I know this guideline actually adds in a section of survivorship care and expanded on it compared to the last guideline. Can you talk a little bit about the emphasis on survivorship care and why the guidelines felt it was important to really emphasize that for our patients?
Yeah, I think first of all, I would say that looking at the epidemiology of differentiated thyroid cancer, I think it's likely that most patients with differentiated thyroid cancer actually achieve complete remission. And the overwhelming majority of patients have very low and low risk disease and have excellent response to treatment. And yet, at least in my practice, we have patients who are being followed for that for decades, 10, 20, 30, 40, or more years. And it is contributing to their cost of care, their unique cost of care, the health system's cost of care, and a whole lot of anxiety. And so the question is, if patients achieve complete remission, and that demonstrates sustainability and durability over a reasonable amount of time, and those data are now starting to emerge, I think it's important to be able to release them from follow up. And there are other patients, those who do not have excellent response to low risk disease, so intermediate, high risk disease, incomplete response to treatment, where it might be necessary to intensify survivorship. So, reducing intervals, increasing the imaging or testing that we are doing to be able to better personalize their treatment.
Yeah, I think precision medicine and personalized care is very important. And as you alluded to, it's not just the financial cost, but the anxiety that comes with like a yearly thyroid ultrasound and a yearly lab test. I have many patients 25 years out who still get that same anxiety trying to get the screening done on a yearly basis. So it would be nice for them to be just living their lives and not have to worry about it even on just one day of the year, but it's still extra worry. So this document has a lot of information. What kind of advice would you have to give to trainees or early career clinicians on kind of what to focus on or what are the big topics?
Yeah, this is something that Dr. Ringel and I and our task force have talked with the American Thyroid Association about. And I would say it's a great question for any of us, including someone like me that lives and breathes guidelines and everything that pertains to differentiated thyroid cancer. There are 84 recommendations, 1,458 references. It's kind of inaccessible. You don't really sit on a beach in August before Labor Day reading the guidelines. So they're kind of inaccessible. So I think one thing that I believe the American Thyroid Association is looking to do is to create a more accessible tool, whether that's an executive summary, an app that can be deployed, in clinic on your iPhone, on a laptop or an iPad or some other technological that makes it easy to personalize treatment based on the unique characteristics of your patient and the on average guidelines that we have. So one is increase accessibility. Two is it's not just our junior colleagues, it's people in other specialties who more and more are taking care of patients with DTC, like family practitioners, general internists, obstetricians, gynecologists, pediatricians. Ultimately, we're going to have guidelines for pediatric DTC hopefully soon. But I think that we need to figure out how to make it accessible. I would say these guidelines are meant to be read, they're meant to be discussed. I think it's okay to argue and challenge them, maybe even disagree with them. And so I hope that people will use the guidelines like in journal clubs, at tumor boards, like bring it to us, like challenge them. And I would say the biggest thing for our youngest colleagues to do is to do the science to improve the guidelines. Like being a scientist or being a physician scientist is probably the most impactful profession. And if our youngest colleagues can create the evidence to inform change that improves the care of our patients through better guidelines, bring it on. I love it.
So, areas for research in case anybody's looking for some more projects in the future.
Yes.
How do you expect these guidelines to change day to day practice? You kind of alluded at it, but do you think it's going to change it dramatically, or it's more of a like a slow process?
Yeah, I mean, as a department chair, I will say that change is hard. Um, None of us like change. I don't like change. And when I talk about the guidelines, before I dig into the references and the recommendation, I always show the authors because, all of us have our lived experience and therefore probably have some implicit bias, right? And so I think it's important to understand that and to understand that change is hard, but we should embrace change where evidence supports the change. And so I think there will probably be areas of the guidelines that will result in more efficient change because the evidence is better, or perhaps the incremental change is smaller. And then there are some parts of the guidelines where there are weaker evidence. Unfortunately, that's many areas, and where the change is more dramatic. And that's where I think we have to continue to discuss, review, revise, bringing people along. Certainly, if you look historically at guidelines from the ATA, we have seen practice change after publication of the guidelines. So I expect there to be change. And I think just remember, everyone should remember, these are not intended to be used for a specific patient, a specific case, right? These are high level. They're on average, what would we do? And that's where I hope every single colleague of ours brings the transdisciplinary wisdom of the team, the care team taking care of the patient, and the patient voice to where necessary amend, or dare I say, realize that the guideline does not apply to the N of one that is in their clinic that day.
Which actually brings me to a little bit too. We have some listeners that are patients. So, how do you think these guidelines will benefit patients?
I hope they improve patient outcomes. For the first time in our group, we had the patient voice represented. Gary Bloom, who is the staff lead for THICA. I would say, not making excuses, woefully overdue to have the patient voice. So I'm so thankful for that. Secondly, he had an impossible job. How do you represent all patients with thyroid cancer? And just thinking creatively, I hope going forward we can find even better ways to integrate the patient voice into guidelines, um, informing iterations, giving feedback. I think we need to bring these guidelines to patients and make them accessible to patients, easy to understand, so that they can ask their clinicians the best questions to inform choice. And so, we're hoping to go to different patient advocacy groups to get feedback to help with the education. But what's the goal? Improve patient outcomes, all patients.
Well, looking back over the years since you've been practicing a lot longer than me, what do you think is the most surprising change in thyroid cancer care over like the last decade or 20 years?
I think you might have just said I'm old, but I'm not sure.
Wiser, wiser.
I'm flattered. I'm flattered. Thank you. No, I'll say, I am not so old, and I have not been in practice so long. I actually think, um, given how challenging change is, how much change there has been in my lifetime. I'm not saying that with regret. I am saying that. And it's also like when I trained as a surgical resident, we did total thyroidectomy for everyone. And for everyone with every stage of differentiated thyroid cancer, including papillary thyroid microcarcinomas. And we often added radioactive iodine to that. And I think the arc has shifted so profoundly where I'm a surgeon who actively talks to patients about not having surgery. It's a subset of patients, it's a carefully curated, selected group of patients, but where I'm actively talking to them about not working with me. And that's absolutely the right thing. So I guess I'm really struck by the degree of change. And I guess where I finish is a absolute belief and allegiance in the importance of science at a time where it probably needs to be said that we need to support science.
I agree. If you had to boil all down for our listeners in like the last 2 minutes, tell me what are your top three takeaways from the guidelines?
Yeah. I would say understanding the importance of the patient journey, the data framework, that the patient always should be in the epicenter of care. We need to listen to the patient voice and, where appropriate, bring that voice actively into the decision making such that it is shared. Two, we need to continue to work to sharpen the knife, so to speak. As a surgeon, I hope I can get away with that. Sharpen the knife to personalize what we do. Every patient is slightly different, and therefore the management strategy probably should be adjusted appropriately, and continue to work to figure out how to do that. And then three, continuing to promote and focus the science strategically. We haven't talked so much today about locally advanced, metastatic. So the patients with the highest risk tumors, where the biggest epidemiologic studies suggest we've made the least progress in survival. And I think the arena of small molecule therapies, druggable targets, clinical trials, I think that is the great frontier, as well as the way front end, which is, do we now understand enough about differentiated thyroid cancer that we can think about prevention? So I would drive us to the two extremes where I think the new frontiers are.
Thank you. Thank you so much for coming on today to kind of help disseminate these guidelines in a more palatable format for our listeners who might not have the time to read the guidelines. We know all our thyroidologists will be reading it and nitpicking every detail of it. So thank you again for joining today. And for our listeners, please stay tuned for our next episode where we're going back to the basics of thyroid and thyroid diseases, about the topic of iodine and its role in thyroid hormone development and the development of thyroid diseases.